record button. All right. Oh, look at the kitty. Sorry. Kind of like that dog from the movie Up. It's like, ooh, squirrel. So, all righty. Okay, and two right here. All right. So when we talk about things that make kids sick, right? One of the first big things are infections, okay? And that could be a virus, it could be a bacteria, it could be a fungus, could be a parasite. Most little illnesses are minor and self-limiting. Just from, my own experience in the past few years of having a kid, Daphne would get a little stuffy nose for a couple days and things like that. And, most kids get over some of those small minor illnesses rather quickly. Things like meningitis, pneumonia, septicemia, pertussis, those are the really severe life-threatening things. And the impact on the child itself really depends on the type of infectious agent and the extent of the infection. So how long they're exposed to it and how severe it is in their bodies. So signs and symptoms can vary. The management is going to depend on what's affected. Always, we're going to take standard precautions to protect ourselves. We want to really be familiar with common pediatric infections encountered in our area. And, we don't really have anything that stands out, but we can grab those statistics from the health department, whenever we want to find out if, and we'll usually, there's a breakout of hand, foot, and mouth in the area, or we have a pertussis infection, coming around, or whatever it may be. And that makes it really important, to watch out for any infections you may not have been exposed or vaccinated for. If you never received a measles vaccine and there's a measles outbreak, it's probably a good idea that you stay away for a little while. In adults, measles can be very, very serious. It actually causes immune amnesia and will wipe your immune system for a couple months afterwards. So we don't play around with measles. So first one, respiratory emergencies. All right. The severity of the respiratory compromise, you have distress, failure, and arrest, just like with an adult. With kids, it can progress very quickly from distress to respiratory failure to respiratory arrest. It'll go through really quickly. Respiratory issues in children are probably the main cause of cardiac arrest in children. When they're in distress, you're going to see that increased work of breathing, that increase in the respiratory rate, therefore having a decrease in carbon dioxide tension. Their mental status will start to deteriorate. They may become irritable or anxious, may not be able to settle if they're very young. You're going to have tachypnea, retractions. You'll see nasal flaring in infants, leading to poor muscle tone, tachycardia, and head bobbing. If you have a kid that's head bobbing, that's pretty severe. So we'll watch for that. It's almost like, I don't know if Dave can agree with me here, but it's almost like a bobblehead. They're like, when they're trying to breathe, it's looks pretty bad. In little babies, you'll also hear grunting. You might have cyanosis or hypoxia that can improve with supplemental oxygen if it's not that severe. But if we don't correct these types of things immediately while they're in distress, it's going to lead to respiratory failure and ultimately respiratory arrest. So respiratory failure, the respiratory system is not able to meet the demands of the body for oxygen intake and for carbon dioxide removal. So this is due to inadequate ventilation and oxygenation, and it ultimately leads to respiratory acidosis. That's the path that this is traveling. You're going to see irritability or anxiety deteriorating to lethargy, very profound tachypnea, which will deteriorate into bradypnea. Marked retractions deteriorating to agonal respirations, very poor muscle tone. That tachycardia is going to start going down to bradycardia. You're going to start seeing central cyanosis, so not just the fingers, but it's going to go full body. This is a very, you get that hypoxia. This is very ominous. If we do not do something immediately, it will deteriorate to full respiratory arrest and then we got a bunch more stuff we got to worry about. When we get to that respiratory arrest level, this is the end result of respiratory impairment if untreated. You're gonna have a cessation of breathing following that bradypnea and agonal respirations, unresponsiveness deteriorating into coma, bradypnea deteriorating into apnea, no chest wall motion, that bradycardia is going to asystole, profound cyanosis, and it will deteriorate to full cardiopulmonary arrest if appropriate interventions are not made. So we know what our 3 levels are. All right. So when we're looking at it in respiratory emergencies, we want to make sure that we have adequate ventilation, adequate oxygenation. Our initial attention is going to be directed towards the airway of a child. All right, is it patent? Is it maintainable with simple positioning? Do we need to intubate? All right, we want to look at these things depending on our level of certification to determine the best possible way to keep that airway functional. Okay. So positioning is our first move. We can look at adjuncts, either oropharyngeal or nasopharyngeal. We can look at endotracheal intubations, high concentration oxygen administration. Right. Any pediatric patient with late respiratory or failure or arrest those symptoms require very aggressive treatment. So when we're establishing an airway, high concentration supplemental oxygen administration, right? We can do mechanical ventilation with a BVM, delivering 100% oxygen, have the oxygen hooked into it. Endotracheal intubation if mechanical ventilation does not rapidly improve that condition. If we intubate, we want to put a gastric decompression with either an oro or nasogastric tube. And you'll see medics do that because babies have a tendency to get that gastric distension because their anatomy is so close together. If we have a pneumothorax appear, we're going to needle decompress. And if all else fails and we've done every single thing possible, we can move as a paramedic to a crike.
So I have a question, actually.
Sure.
So back to the last meeting we had with the G tube. How often is that used in pediatric cardiac arrest scenarios?
How often is what used? Sorry.
The gastric tube.
It should be placed in any baby you intubate just to help. It's not a requirement, but it is a strong recommendation that you place that nasogastric tube. And it's also going to depend. I mean, you got to look at the situation. If it's an obvious, SIDS or this isn't going to come back, if you think you got a chance, definitely put it in. So,
gotcha.
Yeah, it's a strong recommendation.
I think I would also say, Jamie, that cricothyrotomy under, I want to say 8 years old in Maryland, yes. We do needle cric.
That's correct, and we talked about that last week. I showed you guys the protocol. Anybody under 8 is a needle cric. Anybody over 8, you can do a surgical. Yep. We're going to want to obtain venous access. In older kids, we might try for a vein first. In younger kids, we're probably going to go straight for an IO, right? Prompt transport, emotional and psychological support to parents, big thing, because parents are going to be freaking out. So first one, croup, and Dave kind of talked a little bit about these last week. So croup, the actual term for that is this really big, long word, laryngotracheobronchitis is what that says. And it's a viral infection of the upper airway. So you get edema beneath the glottis and the larynx, which narrows the lumen or the size of the airway, right? Severe cases can lead to a complete airway obstruction. Right? Usually you hear most complaints about it happen after dark. You're gonna have that brassy seal bark cough. In kids with croup, don't ever try to examine the oropharynx. Don't stick your fingers down there. Don't try to look in there. In a pre-hospital setting, it's really difficult to distinguish croup from epiglottitis. However, if the child is vaccinated and they've got their HIB, B as in boy, vaccine, it's slightly unlikely they're going to get that epiglottitis. It's probably going to be croup. Kids may develop restlessness, tachycardia, cyanosis. cool mist, air, oxygen, or oxygen by face mask or blow by. And that's one of the things to help with that is that cool air. Okay. The doctor may order racemic epinephrine or albuterol. I don't know how likely that is to happen, but it may, which is just inhaled. Don't agitate the patient by administering non-essential measures. So in any baby with croup or epiglottitis, we want to do our best to keep them calm. Don't poke at them, don't prod at them, keep them from crying because crying is going to make it worse. So here's our protocol on croup. So you have mild, moderate, and severe. Mild is the barky cough exhibited without stridor at rest, which is a priority 2. Moderate is the barky cough with stridor at rest without agitation, may exhibit mild respiratory distress. That's also priority 2. And then severe is stridor at rest, signs of severe respiratory distress that's associated with agitation or decreased level of consciousness is a priority 1 call. Right? So they note here that if epiglottitis is suspected, i.e. you're going to see drooling with the above signs and symptoms, do not initiate this protocol without appropriate medical direction. Right? Very important. So patent airway, if you're ALS provider, we're going to go cardiac monitor. We can give them dexamethasone for mild. For moderate, we can also do dexamethasone, and we can do epinephrine via nebulizer. And severe, if it's so severe that respiratory arrest is imminent, we're going to go straight to the epinephrine, IM, and then dex, right? And then get him to the hospital. And unlike, it's not, you may go on scene with the ALS provider that has a person that's been having some problems breathing and we give them a neb and then BLS may transport. Okay, that I've seen that happen. In the cases of pediatric patients, if we give a nebulized epinephrine treatment, they must be accompanied by that ALS provider. You cannot let anybody else take them to the hospital. Epiglottitis, like I said, this is acute infection and inflammation of the epiglottis, potentially life-threatening. It's caused by this bacteria here, the H influenza, the HIB, right? And because of this vaccine, it's become a very uncommon occurrence. We don't see it very often unless you have an unvaccinated child. It presents very similar to croup, except for you have the drooling. Right? You're gonna have a high temperature, brassy cough, pain on swallowing, sore throat, high fever, shallow breathing, dyspnea, inspiratory stridor, drooling. The child is going to be very acutely ill looking, very agitated.
Hey, Chief, before you get too far, the HIB, is that a vaccination that's required by Charles County schools? And if so, at what grade? So like
you get it at infancy, according to the CDC recommendations, because my daughter got vaccinated for it, because this is when it's the most, when it can affect the baby the worst, causing the epiglottitis. You're looking at HIB vaccination is given first dose 2 months, second dose 4 months, and then the third or fourth dose can be given at 12 or 15 months.
So an appropriate question to the parent or caregiver would be, is your child up to date on vax? And then leave it at that.
Yep.
So if they're up to date on vax, Charles County required vax, then I don't have to say, because like I'm a parent and I can tell you have no clue what all my kids have had. I just know that every time I go to the docs, a doctor sticks them with needles and says this is what they were due. I say, all right, thanks, sir, and I walk out.
Right.
Okay.
I usually just say, I ask parents, are the children current on their vaccination schedule, and that should be adamant. If they're current, then it's highly unlikely, but it's not a complete rule out that it's epiglottitis. It's just highly unlikely.
Roger.
And that's important for anything, because that's one of the first questions the doctors want to know when you get to the hospital with a child that's presenting with croup symptoms is, or have they been vaccinated? So.
I just figured you mentioned it 3 or 4 times so far in this brief, so I figured it was important. But for non-ALS providers, then my basic questioning would be, is your kid up to date on vax? And if so, if not, I would immediately assume the worst and possibly ask for ALS intercept while going to the hospital.
Absolutely. If you haven't figured it out yet, I am a vaccine propagandist.
Yeah, I'm on your Facebook. I've seen it.
So never attempt to visualize the airway in these kids. The epiglottis is going to be cherry red and swollen. You're going to see retractions, nasal flaring, pulmonary hyperexpansion. They're going to be tripoding. right? Try to give them oxygen by face mask or blow by, whichever is not going to upset them the most. So with epiglottitis, we don't do this, but this is the preferred treatment is humidified oxygen. If you have a full obstruction, you can use a two respirator ventilation with BVM is effective because you have that good seal when you have two people. Intubation is actually contraindicated unless it's complete obstruction. And don't try to intubate if you have a short transport time. So around here, our transport time to the closest facility is a couple of minutes. Probably going to just try to BVM them because we don't want to irritate that any more than it already is. As a last resort, just as before, needle crike per medical direction. Avoid IV sticks, don't take the blood pressure, don't attempt to look in the mouth, right? Like I said, we want to keep these kids as calm as humanly possible. All right, foreign body aspirations. Most of you guys weren't on here yet, but my kid stuck a piece of corn up her nose earlier. So, that was a fun day for me. Yeah, a whole corn kernel right up the nostril. That's great.
I had to do that with a Lego. My son had a little round Lego stuffed up his nose. It was crazy.
They have an increased risk of aspirating foreign bodies, especially when they run or fall. And at young ages, all they do is run and fall. So common foods, hard candy, nuts, seeds, hot dogs, sausages, grapes, which is why they tell you don't give babies or kids that are learning to eat until they're like 4 or 5, things that are round, because round is the shape of your esophagus.
Jamie, I'll tell you a little horror story. When I was in, I think, first grade or kindergarten, I was running on the playground, and this was at Mitchell. And I was running around on the playground at the time. They had, the gravel instead of the mulch. And I took a header. I jumped off the swings, landed into the gravel, smacked my face, and ended up with a nose full of, the pea gravel. They took me to the nurse, as quick as MB, and they went in my nose and pulled out everything. I was like, I don't know if you're supposed to do this. But it was awful. That's why I think they've switched to mulch or, whatever.
Now you can just get a bunch of splinters.
Yeah, great.
But, yeah, that's why they recommend don't have anything round. Cut things appropriately. Also, watch out for coins, balloons, small objects. I think it was Mr. Staples and I had a conversation, had a call for a 2-year-old who got into their grandmother's coin jar and ate an undetermined amount of pennies were missing. So.
Oh, were they wheat pennies? Were they
I don't know
special edition?
I don't know, but the grandma said that there were a lot missing, and we don't know if they ate them or put them under the mattress. But
so, Jamie, I had a kid put a button battery up his nose down the street here.
oh my God.
Yep.
Yeah, kids put everything in their nose, their ears, their mouth. They try to put it in other people's noses. Right. So, if we have a partial obstruction, don't attempt to look in the mouth, transport, humidified oxygen. If the obstruction is complete, clear the airway with your basic life support techniques, back blows, chest thrusts. Right. We do not do blind finger sweeps because we may end up lodging it further down. If you can see it, pull it out. We could attempt ventilation with BVM. If unsuccessful, if it is that far down there, we're going to use ALS providers are going to use a laryngoscope to visualize the airway. And if we can see it, we will try to remove it with those McGill forceps, intubate if possible. Lower airway distress, absence of stridor, presence of wheezing during exhalation, increased work of breathing. These are things like asthma, bronchiolitis, pneumonia, lower airway aspirations. So specifically asthma, this is a chronic inflammatory disorder of the lower respiratory tract. Children can succumb to asthma. So pre-hospital recognition treatment is really essential of this. You get bronchospasms, which creates this excess mucus production, and they can't breathe properly. So it's actually an airflow obstruction. That's why it's an obstructive disease. The airways become hyperresponsive, and lots of different things can trigger asthma. You can have environmental allergens, sudden bursts of cold air, exercise, different foods, emotional stress, certain medications, all different things. So you end up with this bronchoconstriction and this bronchial edema that effectively decrease the expiratory airflow, causing the classic asthma attack. Now, some people may respond to inhaled bronchodilators. Okay, some may not. And you have to think about it. When somebody's having an asthma attack, how are they breathing? Fast or slow?
They're breathing slow, but it's a forced breath. It's like they're really pushing hard to get the air out.
Well, that's towards the end, but at first they're almost hyperventilating because they're scared. So their respiratory rate will actually increase, and you hear that wheezing. They're trying to catch their breath, but nothing's really going in. And if you try to give them their inhaler, that medication isn't going to get very far down into the chest because they're not taking those full breaths enough to get down. That's why nebulizers may be a little bit more effective because it's constant, not just a puff. The bronchioles, you know, they're the cells in the immune system, they get invaded, right? You get additional edema, which again decreases that expiratory airflow. At this point, when it gets really bad, they may be unresponsive to inhaled bronchodilators. You're gonna have to give them corticosteroids. We do carry dexamethasone, just give this. You're gonna see swelling of the mucous membranes. It's gonna worsen. It's gonna get plugged up with all this thick mucus. It's gonna further obstruct the airflow. Everything is going to just start trending down. So we gotta make sure we treat asthma very quickly. If untreated, they're gonna eventually go to unconsciousness and death. So medications, inhaled or nebulized beta agonist drugs, that's your albuterol. You're gonna see the child sitting up, leaning forward. They're gonna be tachypnic, unproductive cough. You may hear wheezing. If they have had an asthma attack and they stop wheezing, that's a very ominous finding. Please be aware of that. Using your pulse oximetry and capnography can help assess the severity of the asthma. So what we want to do is correct that hypoxia, reverse the bronchospasms, decrease inflammation. We're going to establish an airway, give supplemental humidified oxygen to correct the hypoxia, and that inhaled beta agonist. So in Maryland, assist the patients experiencing moderate to severe symptoms or mild symptoms with a history of life-threatening allergic reactions with their epinephrine injector if it's a result of allergic reaction. Or fast-acting bronchodilator, 2 puffs once within 30 minutes. Consider additional dose of that bronchodilator or an epinephrine. For the ALS, if we're moderate to severe, high-flow oxygen with non-rebreather, we can use CPAP or BVM while receiving medications via NEBS. We have a little thing here, a combination of albuterol and Atrovent. For an infant less than 1, we don't give Atrovent for anyone over the age of 1. We have a dose there. Over the age of 2, we go to full dose. If we have to give a second neb, it's going to be albuterol only. Atrovent's only on the first one. We can also, after medical consultation, if they have a congenital heart or chronic lung disease, we can give epinephrine and dexamethasone. Now, at the end here, we can consider mag sulfate to a max of 2 grams as an IV infusion. But it can cause hypotension in children, so we might want to consider giving some fluids with that as well. Backwards. All right. Shock in kids or hypoperfusion. We kind of talked about shock the other day, so I'm not going to get too in depth with this, but you know, basically what's going on, we don't have perfusion of the tissues with oxygen and other essential nutrients, and we're not removing the metabolic waste products. So you end up with tissue hypoxia, metabolic acidosis, and eventually death. Right, you know that. It's unusual that it happens in kids, and the blood vessels constrict because blood vessels constrict really effectively in kids. So it's very unusual. But when the blood pressure does drop, it drops so far and so fast that cardiopulmonary arrest is almost imminent. Remember, I said kids go along that cliff there, and then they just right off the end. So things that can, you know, other things that we can look at here: hypothermia. Dehydration due to vomiting and diarrhea, infection, trauma, blood loss, allergic reactions, poisoning, in rare cases, cardiac arrest. These can all lead to these shock-like situations. Definitive care for these patients, the ER, right? It can be life-threatening in pediatric patients, so it's very important to recognize those early signs and symptoms, provide oxygen, rapid transport. like I said, this little view, we have compensated, decompensated, and irreversible stages. We kind of went through this before. In kids, it's really important if they're unusually irritable or anxious, that's a sign of shock, combined with tachycardia, tachypnea. They're going to have weak peripheral pulses, but full central pulses. So maybe weak down at the brachial, but full if you go to the femoral. You're going to see that delayed cap refill. It's super important, vital sign in children. You'll have those cool, pale extremities. You'll also see decreased urinary output. This is something that we can generally reverse because kids do compensate for a longer time very well. When we get to that decompensated shock, we're not compensating anymore. Everything's going to start going down that cliff in a rapid fashion. Blood pressure is dropping, end organ perfusion, loss of fluid or impairment of cardiac outputs occurred. You're going to see lethargy or coma, marked tachycardia or bradycardia, absent peripheral pulses, weak central pulses, severely delayed cap refill, cool, pale, dusky, mottled extremities. Hypotension, severe urinary output decrease, absence of tears is a big one. This is irreversible if we do not take aggressive treatments. So we want to treat that underlying cause, use that BVM, get them back up with 100% oxygen, do our best to get them to hospital as quickly as possible. And then you have irreversible shock. We can't really do anything for that. Hence why it's called irreversible. Got a couple different kinds. You got non-cardiogenic shock. This is causes other than inadequate cardiac output. We got hypovolemic, so loss of fluids, distributive, septic, so lots of different types. We're going to talk those. When we think of sepsis in a kid, you're going to have that ill appearance, irritability, altered mental status, fever, vomiting, diarrhea, cyanosis, pallor, mottled skin, non-specific respiratory problems, poor feeding, all indicative of sepsis in a baby. Very ill appearance when you hit that septic shock, altered mental status, tachycardia, cap refill greater than 2 seconds, increased breathing, clammy skin. The child may not recognize the parents. Right? These are all very bad signs. So for that, just like the other regular shock, supplemental oxygen, IV access, look at epinephrine. Seizures. So there are lots of things that can cause seizures in kids. And what a seizure is an abnormal discharge of the neurons in the brain. Things like fever, hypoxia, infections. You might have idiopathic epilepsy, which means they don't know. Electrolyte disturbances, all can result in seizures, as well as your head trauma, hypoglycemia, ingesting things that you're not supposed to, different toxins, tumors, and central nervous system malformations. When we look at partial seizures, these are focal motor, so you'll have a sudden jerking of a specific body part, maybe like an arm or a leg. You might see lip smacking, eye blinking, staring, confusion, lethargy, no loss of conscious. Generalized seizures, sudden jerking of both sides of the body, followed by tenseness and relaxation, and there will be a loss of consciousness. Patients may go status, what we call status epilepticus. This is a serious medical emergency. So this is a prolonged period of apnea, which can cause hypoxia of the vital brain tissues. And then lastly, you may see febrile seizures. And febrile seizures are usually pretty benign. They're really scary to watch, but they're usually benign. And this is a result of a sudden increase in body temperature. And I hear it mischaracterized all the time that the temperature has to be like above 103. It doesn't. The seizure is caused by the rapid increase in a short amount of time. You can have febrile seizures with a fever of 102. If it was suddenly like 99 and went to 102 very quickly. So it's that very rapid.
Barry and I, actually my sister was on it, had a transport about a little over a year ago where we had a kid that had come from patient first. No, it was from the actual children's suite. That it was, he'd had a seizure, but his temperature went down to 100.2. And we ended up transporting him priority 3 because he was all right. We took him home with him. He was past the pat. Like he was talking with his mom. It wasn't he was still kind of suspicious of us. We were like, okay, we'll go priority 3. He's supposed to stick to cool beans. We get him transferred to Trauma Bay 3, and we monitored. We took his temperature twice en route, and it was starting to go up just a little bit. Like I think he reached like 100.6 or something. We transferred him to a bed, and not 5 minutes later, they called, or he started having Barry had never seen a febrile seizure in a kid. And so we were like, oh God. But his temperature went from 100.6 to 102.7.
Yeah.
Like that.
It's super scary.
It was like, oh my God.
Yeah.
So, yeah.
But any pediatric patient that suffers a seizure needs to be taken to the hospital, just to be safe. We want to determine if there's a history of seizures or seizures with fever. So pay very good attention to the adequacy of the respirations, the level of consciousness, signs of injury, dehydration, all those fun things. If they're actively seizing, put them on the floor of the bed, lay them on their side. We use the recovery position away from furniture. Do not restrain them, but we take steps to protect them from injury. Right? We want to try to maintain that airway, but don't force anything in their mouths to between the teeth. Right? If they bite their tongue, they bite their tongue. It happens. If they become hypoxic, give them that supplemental oxygen, record your vital signs. If they are febrile, if they do have that fever, get the excess clothing off while avoiding extreme cooling. So we're going to try to slowly pull them back down. If they are status epilepticus, IV of normal saline or lactated ringers, we're going to use ringers here. Use a glucometer because seizures will drop your sugars. And we can give midazolam 0.1 milligrams per kilograms in 2 milligram increments, max of 5 in Maryland. Any questions so far? There's my kid eating an apple. Yay. All right. I take like 40 pictures of my child a day. I have a whole bunch, trust me. All right, so that's medical. And we're going to kind of talk about trauma. All right, so with pediatric trauma, common mechanisms of injury: falls, car accidents, car versus pedestrian, drownings, penetrating injuries, burns, and then lastly, physical abuse. So falls are the most common cause of injury in kids, all right? You know, my kid right now is covered in random bruises, and I like to tell everybody that she does her own stunts because she does. She jumps off of everything and tumbles and falls, and it's crazy. Motor vehicle collisions are the leading cause of traumatic death, permanent brain injury, new onset epilepsy in kids. Improperly seated children are at an increased risk of sustaining injury or death from an automobile airbags when they deploy. Does anybody know at what age you can turn you should stop rear facing your child's car seat?
Is it like 3?
So technically in the state of Maryland, you can turn your child around forward facing at the age of 2. However, their spinal cord has not fused properly yet. So it is highly recommended, albeit not illegal, to leave your child rear facing until they max out the height and weight for their particular seat. That is that. Car versus pedestrian injuries. This is a lethal form of trauma in children because their short stature pushes them down under that car. You can have submersion or immersion injuries from drowning. So with drowning, we look at the different outcomes. So no morbidity or no injury. Morbidity is injury and mortality is death. So if you hear those words, that's what they mean. Older terms, we used to say near drowning. It's not actually, we don't use that anymore because drowning is a process, not an outcome. It's fatal or non-fatal drownings. That's how they're described. 20 to 25% of near drowning survivors, like I said, we don't really use that term anymore, but exhibit severe neurological deficits. Outcomes are usually better when water is cold. What is that reflex called? Anybody? Cold water reflex. Charles, you're a freaking dive team member. Come on.
Yeah, I forgot. It's the balls jump up into your throat thing.
What was that? Somebody said something.
Now,
It's the mammalian cold water reflex, basically. Mammalian. Oh, wait a second. I got chat going on over here. Who's chatting with me?
Yeah. Yeah, I think I was taught it's called the glick response for children. They tend to just, I don't know, go into a coma and hang out or something.
Yeah, they get they're basically because the cold water slows everything down for you. You know, that's what hypothermia does. They get that reflex, and it actually can help them a lot better. And best treatment for a drowning victim is prevention. So don't let the kids near the water. That's right. Unsupervised. You got penetrating injuries, stab wounds, firearm injuries. I've seen 2 cases in the past week of little kids that got a hold of their parents' non-secured weapons and shot their siblings or friends. Completely avoidable. Completely avoidable. Yeah. External injuries do not provide adequate evaluation of internal injuries. Remember, all their organs are squished up a little bit differently than an adult. You got burns. This is the leading cause of accidental death in the home for children under 14 years of age. Kids, they start exploring. Like, my kid now knows that she can push a chair over to the stove and look inside the pots when I'm cooking, and it scares the living bejesus out of me. Right? And then lastly, you have physical abuse. Right? Things like poverty, domestic disturbances, younger parents, people that have substance abuse issues, community violence. Document your findings and report to the authorities. We are mandatory reporters, so if there's any sign of physical abuse in your patients, we're going to automatically report that to the hospital when we get there. Airway control, always maintain that inline stabilization in neutral instead of the sniffing position. If they're hypoxic, give oxygen. You use suctioning, jaw thrust maneuver. Be prepared to assist in those ineffective respirations. If you can't maintain it, intubate them. All right, gastric tube to decompress the stomach. Again, needle crikes, rarely indicated for traumatic upper airway obstructions. With stabilization, we're using a rigid cervical collar. We can use a towel or blanket roll. We can use a child safety seat. If the kid's in the accident and the seat's not damaged or doesn't appear to be damaged, leave them in it. All right? We can use a pediatric stabilization device or the KED. I love the KED for pediatric patients. Right. I love the KED for pediatric patients. Dave has a comment though. Back to the.
I was going to wait.
Oh, that's okay.
So I was going to talk about the reporting for a minute. We have a misconception, which mostly comes from MIFRI and history, where we think that if we go to the hospital, that our obligation for reporting of abuse or suspected abuse stops at telling the nurse behind the desk. That is not the case. There are 2 places where we can legally report. Now, we should report it behind the desk, no question about that. But our legal obligation is to report it to one or both of 2 entities, Child Protective Services or the police, or both. And I strongly recommend that you do both.
Absolutely.
And you do it. Okay, so don't be fooled into being talked into, as long as you report it to somebody at the hospital, the nurse that you hand over to, the person behind the desk, that does not meet the minimum requirement for your obligation. Child Protective Services or the police, or both. And I recommend both. Absolutely.
Great point. So stabilization, like I said, I love the KEDs for kids. They fit right in there, nice and snug. You got short boards, straps and cravats, tape. Remember that we want to pad all of our open spaces when we're boarding a kid. For fluid management in our trauma, management of airway and breathing is a priority over circulation. Okay. If possible, we want to try to get a large bore intravenous catheter into a peripheral vein. Don't delay transport for venous access, though. We can do it en route. Intraosseous is alternative when our peripherals cannot be obtained. So go ahead straight to that. Fluid bolus for kids, 20 milliliters per kilogram of lactated ringers. reassess our vital signs to see if there's any improvement. We can give another 20 mils per kg if there's no improvement. But if we don't have that second bolus, a likely blood loss may require surgical intervention, so we're probably not going to give any more than that. With traumatic brain injuries, got our Glasgow coma scales, right? If it's 13 to 15, that's what we call mild, moderate is 9 to 12, and severe is less than or equal to 8. Because those head injuries can cause intracranial bleeding or swelling, and this are really, really bad situations for kids. When you see an increase in intracranial pressure, you'll see a higher blood pressure, you'll see bradycardia, rapid, deep respirations progressing to slow, deep respirations, right? You'll see bulging fontanelle in infants, so the soft spot in the front and in the back will be bulging out. When you think of herniation, you'll have asymmetrical pupils, and you can see decorticate or decerebral posturing. So decorticate is when they posture towards the core, everything's sunk in this way. Decerebrate is posturing away from their body. This is usually an irreversible injury. We're going to give them that supplemental oxygen, ventilation, consider intubation if the GCS is less than or equal to 8. Specific injuries, you know, a lot of kids who sustain multiple traumas are going to suffer head or neck injuries. You got bicycle collisions, falls from trees, car versus pedestrian, sporting events. You know, diffuse injuries are common in children, and focal injuries are rare because they're so small. Most common facial injuries are lacerations secondary to falls. Anytime we have a kid that has a severe injury, assume neck injury is present. Most injuries to the chest and abdomen are a result from blunt trauma. Extremity injuries are limited to fractures and lacerations, usually because of falling. You'll see those bend, buckle, and green stip fractures. We want to obviously perform splinting to decrease pain and prevent further injury or blood loss. Burns, chemical, thermal, electrical burns. Right, like I said, kid put everything in their mouths. Common type of burn with kids are scalding. Remember the rule of 9s, we talked about burn injuries, 9% of the body surface area to each of the 11 regions. But in children, the head is a larger percentage of the BSA, and the legs are smaller. All right, SIDS. This is something we all may run across. Sudden infant death syndrome. All right, and there's actually another category, it's SUID, which this is under, which is sudden unexplained infant death. All right, so sudden infant death syndrome is a sudden death of an infant during the first year of life from illness of an unknown etiology. It is not caused by unsafe sleeping conditions or external suffocation from blankets or pillows. It is not related to allergies of cow milk or regurgitation. It is not thought to be hereditary. So in order for the medical examiner to give a ruling of SIDS, there must be no other reason determined for the death. Literally, they don't know. Okay, they've run all the tests, looked at all the evidence, everything is there. There's nothing there for them to say. That's when they call it SIDS. And I can tell you that the investigations for SIDS are insanely thorough. I have a good friend of mine that works part-time for the medical examiner's office, and they were explaining this process to me because I wanted to be able to give you guys a really good explanation. When you have a child that dies of SIDS, they have to go in and take photographs. One of the most lengthy part of that process is wherever the child was found, they take an initial photograph and then they move one thing away. So they will say the kid was found in their crib with lots of stuffed animals and blankets and all these things. They'll take an overall picture, take out one item, take another picture, take out one item until they get down to bare mattress. And then they often will introduce a doll to the parents so that they can simulate how the child was put to bed and how the child was found. It's a very, very traumatic experience for everybody involved. But it does happen, albeit rare. It may result from immature respiratory center in the brain. The child stops breathing for some reason. It may be airway obstruction, but SIDS is strongly linked to the prone sleeping position, all right? So that's why we have the ABCs of sleep. Infants should be alone on their back in a crib, right? That has been the most successful reduction in safe sleep. That safe sleep campaign has been the most successful reduction in SIDS the United States has seen. You may see some intrathoracic petechiae, pulmonary congestion edema. Unless the infant is obviously dead, We undertake active and aggressive care of the infant to ensure the family, everything as possible is being done. Right? And you have to have those obvious signs and symptoms of death. After arrival at the hospital, direct management, parents or caregivers, nothing can be done for the child, right? Allow the family to see the dead child. Expect a normal grief reaction. And this last statement I have here, it may affect you. We have post-incident counseling available at no cost. It is strongly recommended that you participate. And I'm going to say that you're not going to get out of participating. When I was in my first semester of paramedic school, very first semester, I ran a child that they found not breathing. She was a 7-month-old infant from Cobb Island to La Plata. That was the longest 45-minute transport of my life, doing CPR on a 7-month-old child. I can say the one thing that helped me the most with that was the critical incident stress debrief that we were required to attend after the incident. Right? There is no shame. I cried for all that afternoon. I went home. I did not want to. I almost said, screw being a medic. Right? There is no shame in being upset. There's no shame in being angry. There is no shame in asking for help. Pediatric death, pediatric injuries in general are some of the hardest calls you will ever run. Please, please, please reach out to help. Right? Cannot stress that enough. ALTs, or apparent life-threatening events. So when a kid has an ALT, they become apneic, they change in color, they lose muscle tone, they may cough, they may gag. You may need to use stimulation or resuscitation to arouse the child to reinitiate that regular breathing. So this is an apparent life-threatening event. Any of these things qualify for it. In the state of Maryland, the inclusion criteria are the apnea, the skin color changed, change in muscle tone, and choking or gagging not associated with feeding or a witness foreign body aspiration. Right? When you get there, these children may appear stable and exhibit normal physical exam assessments. However, episodes like that may be a sign of an underlying serious illness or injury. So they need further evaluation. So we'll do that initial assessment using your pediatric assessment triangle, obtain a description of the event, get a medical history, oxygen, be prepared to assist with ventilations if this episode can occur again, cardiac monitor, and we want to get them to a pediatric center, try to get them to children's. Most time we can fly these. If the parent refuses medical care or transport, the clinician shall, and that is in capital letters, shall contact a pediatric base station physician, which is whom? Only got one.
Children's.
Thank you. That is Children's Medical Center. You cannot do this consultation with Charles Regional. You have to consult with Children's online. Right? As part of the refusal. When we think about child abuse and neglect, this is any physical or psychological harm to kids. Yes.
Hey, I'm sorry to cut you off, but so the parent says they refuse transfer to the child, we contact Children's. I just wait around to see if the doctor argues with them well enough to get it on, or what? I mean.
So you're gonna consult with Children's and CRMC, because we want to have our local plus the pediatric base station on. And you're going to explain the situation to that physician, and the doctor is going to give them, talk to that parent and tell them this is why your kid needs to go to the hospital, so that if 20 minutes after we leave, that kid dies, we're not liable, because we have that physician on a recorded line hearing the parent say, no, my kid is fine, I'm not going to the hospital, while everybody else is saying, no, your kid needs to go to the hospital.
So in addition to the consult, I need the parent or the caregiver in the AMBO listening and participating in a conversation.
Yes.
I actually have a comment there, Charles. One of the major advantages of using your cell phone to consult is that you don't have to be in the ambulance. I find that because you're using Simplex, and you've got a key button, trying to do a consult with a parent where the parent and the doctor are trying to communicate, having that simplex communication through the base station radio, which is not the best at the best of times, is actually just an impediment to you. So it's actually much better to do that consult through your cell phone, go through CRMC. Did I say that right? Go through
EMS.
EMRC. Go
Too
through,
many.
yeah, I know. Go through EMRC, and then you know that that it's being recorded. So never go direct. Always go through EMRC, and use your phone, and then give that phone to the parent to talk to the doctor, and that way they can clearly hear, and they're used to talking on a phone on a duplex system.
Understood.
Yeah, the phone number for EMRC is in the front of the protocols, so you can dial in. With child abuse and neglect, kind of like we talked about before, this can be any physical or psychological harm to children, intentional or abuse, or intentional or unintentional neglect. Maybe the child is seen as special or different. Your premature infants and twins are at higher risk of abuse than other children. Less than 5 years of age are higher risk. You're physically and mentally handicapped are higher risk. People that are uncommunicative. Boys are more often abused than girls. You know, a child who is not what parents wanted is usually at higher risk. So people that are perpetrators of abuse or neglect, could be the parent, could be a legal guardian, could be a foster parent, a person, an institution, an agency, a program entrusted with custody, actions of the caretaker, anybody can be a victim, and anybody can be a perpetrator. Usually, the abuser is usually a parent or full-time caregiver. Usually, not always. Most abusers were abused themselves as children. Again, usually, not always. Parent or adult who seems capable of use, especially one who exhibits evasive or hostile behavior. All right, that's a key there. The child's usually going to be in a high-risk category. There's going to be a presence of crisis, particularly financial stress, marital relationship stress, or physical illness in the parent or child, all contributing factors. So the different types, you have psychological, physical, sexual, neglect, either physical or emotional. And your abused children are going to suffer every imaginable kind of mistreatment. And I'm not going to talk about it all because it'll just make everybody depressed. But it's out there. Sexual abuse can range from adults exposing themselves to overt sexual acts. It can occur at any age. Yeah. So with these children, any obvious or suspected fractures in a child under 2 years of age, multiple injuries in various stages of healing, especially burns and bruises, more injuries than usually seen in the child of the same age or size, and injuries scattered on many areas of the body. These are all clues that may lead you down the road to thinking this child may be a victim of abuse. You may see bruises or burns in patterns that suggest intentional infliction. Suspected intra-abdominal trauma in young children, or any injury that does not fit with the description of the cause given. Right.
So I got a comment to make on this one.
Sure.
So let me ask people's opinion. Could an accident be considered not abuse, even though the child is severely injured? And I'll pick an example. Say a child is burned having a bath with water that's too hot, and that was a genuine accident. Is that abuse, and would you report it? Any opinions?
Yeah, I would report it, but it's not my job to figure out if it's abuse.
No,
That's what the,
that was the right answer that we were looking for to begin with, right?
okay, so,
We're not the judge and jury. We're not the police. We're not Child Protective Services. All that we can do is report what we see and keep our opinions to ourselves.
Right.
And therefore, whether we think something was an accident, we neither should give somebody a break because it was an accident. We really don't want to cause this family any more trouble. They're clearly very, very sorry about what happened. Just deal with the medical aspect of it. Nor should we take a position of, well, we're really not sure, but we suspect there might be something, but we haven't got, our gut feeling says that we're uncomfortable about it. If
Can I add something to that, Chief, though? So I've actually been on a couple of these cases through school and through other avenues, but when you talk to the Child Protective Services, don't elaborate. Like, don't,
Exactly.
yeah, if they say, well, what is your opinion of this? Unless you're 100% sure, I wouldn't put an opinion. I'd say, I'm not sure. I just know that this is an incident and it needs to be reported. You figure that out. The reason being is you just involved yourself into a court case.
Well, yeah, I mean, you're involved anyway, but I think the point that you're making, and you're absolutely
Your
right.
statements are used now.
Yeah, but the point that I'm making is you don't have an opinion, you're simply stating facts. And our job is to make sure that those facts are properly reported, no less and no more. Not emotionally, not in anger, not avoiding reporting something because we kind of just feel bad about it. It doesn't matter what we feel like. Our job is to report those facts. And it's a dilemma that you'll face. I mean, there's no question it's a dilemma that you'll face. You really don't want to be that person that causes this family more pain. But having said that, you are there as an advocate for the child, and you have to make sure that you report the facts, only the facts, to the right people, because you're an advocate for the child, and everything else is irrelevant.
Correct, and that's why
Really just have a snapshot in time. You don't have any of the facts, anything. Talk about what you've seen, and that's it. You have a snapshot. That is it.
And that's why our report writing on cases where we have our report writing in general needs to be very specific and not include emotion, not include supposition. It's the facts. Think of Dragnet, just the facts, Jack. Okay. So when our assessment of these types of cases, medical history may raise your index of suspicion, like the history doesn't match the nature or severity of the injury. You may get vague parental accounts or accounts that change during the interview. Accusations that the child is injuring themselves intentionally. They delayed seeking help for the kid. The child may be dressed inappropriately for the situation. Comments by bystanders, especially siblings, okay? Extreme malnutrition, multiple insect bites, not like mosquito bites because I get torn up, but like bed bugs, things like that. Long-standing skin infections, these are all signs. Extreme lack of cleanliness, verbal or social skills far below those you would expect for a child of the similar age and background, and lack of appropriate medical care. These are all triggers for us to go, something else may be going on. Let me pay attention. So in management of these cases, we're going to always do appropriate treatment of the injuries. We're going to do our best to protect that child from further abuse, which means we're going to get him to the hospital. Okay. Notify those proper authorities, like Chief Sitter said. Document all findings or statements. We are not there to cross-examine the parents. That is not our job. Our job is that patient. Our job is getting them to the care they need. All right. Never leave transport to the alleged abuser. We are going to do everything within our power to make sure that child is transported with us. We're not going to go, oh yeah, sure, mom, it's not that bad. You can go ahead and take them to the hospital. Right? It's not how this works. Right? Contact our local child protection agency. Consider taking a course in recognizing child abuse. There are courses like that. There are lots of internet sites that provide up-to-date information on that. So CPS, local sheriff's office, and the nurse.
And if anybody gets one of these cases and you're not sure what to do, you're not sure who to contact or when to contact them or how to contact them, contact Jamie, contact myself. We will get you in touch with the right people and make sure that the information gets to where it needs to get to. Don't be surprised if something which you were shocked about and want to be reported to and almost incensed about is not treated the same way by either the police or CPS. Same with APS, Adult Protective Services. On the occasions I've been involved in these things, I am absolutely horrified at the lack of intensity that you see from the people that you're reporting it to. However, that's not because they're just immune to it. They're not. It's because they follow a process. And our job is to make sure that they have the evidence that they need to be able to properly investigate. And I can't stress it enough, because you're never going to be in a situation like that where you're not going to feel emotionally involved. I'm going to give you an example. I know we don't want to do C stories here, but I'll give you an example. I think the worst case that I've had, the worst case that I've had in a young girl was a call for, it was actually a BLS call. I happened to be the closest medic, and it was for a full, I think, hemorrhage. I got there, there were 3 or 4 young girls in there looking after the 5th. The house looked like something out of Nightmare on Elm Street. There was blood up the walls, there was blood up the stairs, there was blood in the upstairs bedrooms, it was over the walls, it was everywhere, everywhere. She had had a miscarriage. They didn't know what to do with it. And they basically had, she'd been in miscarriage in the process of having a miscarriage for several hours. And that's why there was blood everywhere. So you treat it, that's my primary issue, is a miscarriage. She was 12 years old. Now, when you've dealt with the medical aspect of that, is that abuse? I think so. And the reason I think so is, I don't know what your math's like, but my math says that's statutory rape in anybody's book. And therefore, it needs to be reported to the police, Child Protective Services. The police weren't interested. I physically went and talked to the police. I went to the police station and talked to the police. And they said, what do you want us to do about it? They didn't want to go there. That shocked me. And it was only after I went to CPS and said, this clearly is a statutory rape situation. It can't not be. Clearly it isn't consensual. You are going to do something about it, because if you're not going to do something about it, eventually I have to say, I'll go to the police. And I'd already been there and they'd already ignored me. And CPS did something about it. And I went back to the police and I said, if you don't do something about it, I'm going to go to CPS. And one of you's going to look really bad. And eventually they both did it. And it turned out that an uncle in the family was the perpetrator. If I hadn't have been tenacious about making sure that that was properly reported, there were other children in that household. And also that young girl had to come back into that household, right? So you are the child's advocate. Always remember that. You may be the only person that is willing to speak for that child, and it's your job. So make sure you do it.
And let me just say that any call involving a pediatric patient where the outcome is not desirable, they don't have to pass away, they don't have to die, but some calls where you may see abuse, or you may have to make a report like that, our critical incident stress debriefing team is available to you. Because like I said before, the pediatric patients are the ones that really, truly will get to just about everybody. Don't bottle it up, don't hold it in. Okay, reach out to one of us and we'll get you hooked up with our team of people, right, at no cost to you. Available 24 hours a day, 7 days a week. Trust me, Miss Courtney Shannon does not care if I call her at 2 o'clock in the morning for this. It's not a big deal. So we will make sure you guys get what you need.
About two or 3 years ago, up till 2 or 3 years ago, CSID used to be mandatory on calls, and 2 or 3 years ago they changed it to optional. And I think that is a terrible mistake. And the reason is because it's so easy depending on what the type and the nature of the call is, for somebody to say, it's okay, I got this, I'm good, I'm fine. And the bottom line is that many of these situations, you don't know what you are until sometimes weeks afterwards. And it's really, really important. And the right way to do CSID if you're a OIC or a PMIC is call communications and actually request CISD. Because that's where it's dispatched from. Now, if you call either Jamie or myself, we will also call Courtney because she will be given the job locally and we can tell her that that's the case. But I think I've done CISD, probably 6 or 7 times. And the first time I was really uncomfortable about it because I'm not somebody who talks about my feelings, right? And most people are like that. It's like, suck it up, move on, walk it off. Particularly if you're a guy. I will just tell you, that's a really, really bad idea. And so I don't like the fact that it's not a requirement, but unfortunately that's the way it is. But I can only strongly recommend that you do go to see CISD, and we'll help you. And it's totally private. It has helped me enormously over multiple calls.
And the reason I'm going to stress that, I'm only going to take up a couple more minutes of your time, but there's one thing that I did want to include. I'm about to share my screen here real quick. This is the new termination of resuscitation protocol, effective August 1st. BLS clinicians may not terminate any resuscitation for pediatric medical arrest patients. You may terminate resuscitation for pediatric traumatic arrest patients under the age of 15 if ALS resources are genuinely unavailable, which is never going to happen in this county. The patient has received a minimum of 15 2-minute cycles of high quality CPR, and during the 5 AED analysis immediately prior to tour, there was no shock advised. Now, if it's traumatic, you cannot call it for medical as a BLS provider. Other things in there, ALS, we have some other things to take into consideration. Pediatric patients have received 15 2-minute cycles of high quality CPR at 1 dose of epinephrine, and the patient is in asystole, has a sustained ETCO of less than 15. In the judgment of EMS and law enforcement on scene, there is adequate social, emotional support and safety for civilians and professionals on scene, and the scene is amenable to leaving the patient on scene. Okay. If the patient does not meet the TOR criteria, we continue resuscitation and reevaluate the next rhythm check. The other thing that is in here for pronouncement of death in the field is everybody has to agree. If one provider there on the scene does not agree with whoever is doing that, you can't do that in the field. Right? Everybody has to be in agreement. This is new. I don't see us using it ever, hopefully. But this is on page 67 of your protocol book. So you have that for your records. Any other questions?